Just before I start, I would like to just factually correct the Secretary of State, who claimed that Barnett consequentials in Scotland are not passed on. I can reassure him they are all passed on, but when he talks about it in a percentage, because Scotland spends £185 a head more and £157 a head more on social care, of course it is a smaller percentage. Yep. But in actual cash, Barnett consequentials, they are all passed on. So I would be grateful if he would either improve his maths or stop repeating this narrative. Now, there are some things I really want to welcome from the Queen's speech, particularly the Healthcare Safety Investigation Bill. I was asked to serve on the committee, and I felt the committee did an incredible job, which we completed last July. So we are now approaching a year and a half on, and sadly that bill has not yet come forward, and therefore I hope it will not be too tardy from this point.
It's in the other place at the moment.
Okay, I welcome that. I would, however, suggest that the Healthcare Safety Investigation Bill is about looking at mistakes after they have happened, and I would again invite the Secretary of State to look at the Scottish Patient Safety Programme, which is over 10 years old and has reduced hospital deaths by over a third, including post-surgical deaths, because actually the aim is to prevent harm in the first place. I also welcome his reference to whistleblowers. But it isn't just about having guardians in hospitals. It is critical that the Public Interest Disclosure Act is reformed. Only 3% of employment tribunals are successful. And therefore, all of us who have taken anything to do with this will know that the wreckage of whistleblower careers acts as an absolute brake on people coming forward. And you can say what you like, they are faced with this: do I speak up? And do I risk my career, my family income, my home? And therefore, it's not just a matter about paying lip service to this. We actually need change. I also have to welcome the ending of PFI, which was actually originally brought in under a Conservative government, but really accelerated, I'm afraid, under Gordon Brown. And what we are facing is £13 billion worth of hospitals in England will have cost £80 billion by the time they're paid off. So I would call on the Secretary of State not just to end PFI going forward, but to actually look at whether these contracts could actually be ended, could be renationalised to avoid another £55 billion having to be paid over the next 30 years. And this is UK-wide. In Scotland, we were saddled with these as well. And there are health boards across England who are paying up to 16% of their income on their PFI. And that obviously undermines patient care. I will happily give way.
An absolutely perfect point in this particular area. I had the honour of being the roads minister, and when I desperately asked my officials to look at the PFIs on our motorways and on the M25 around this country, the cost of coming out of these contracts is so formidable that no government would do it, simply because their lawyers, frankly, were a lot better than Gordon Brown's lawyers when they wrote these contracts. And we are trapped in this way. And some of the trusts, and not least the trust around Romford, I think, actually has a polyclinic alongside of it as well. So the debt they have from the private sector makes them completely inefficient and traps them into debt.
I thank the honourable gentleman for his point, and it is of course that governments can borrow at a much lower interest rate than any private business, and this is one of the ways that money is being sucked out of all UK NHSs through PFI, but there are also other methods where money is being sucked out, particularly of NHS England. And that is from the Health and Social Care Act, obviously outsourcing. Private companies have to make a profit. Their chief executive is bound to make profit for the shareholder. They are not bound to deliver quality of care. And what we have seen is also clinical commissioning groups get trapped into that. 6 commissioning groups in Surrey tried to bring a community care back into the NHS. They weren't breaking a contract. But Virgin did what Virgin always does. If they don't get a franchise renewed, they sued them. And it's all hidden behind a commercial veil. But we know that at least one of those commissioning groups paid over $300,000 to settle out of court, and therefore 6 together is likely to be well over $2 million. And the problem is...
I'm agreeing with almost everything she says about PFIs. We got a terrible PFI in Halifax called around. It was still a millstone around our necks. When I chaired the Educational Skills Section, we looked at PFIs. They are financial agreements, and some were better than others. And that's the fact. But a lot of very clever city types came to places like Halifax, ran rings round them, and they got a bad deal. That's the truth of the matter.
I think this is true, but obviously this actually applies in the bidding and tendering for delivering services. You know, an NHS orthopaedic department will not be able to compete with a major multinational with regards to their bid team and their tendering team and their ability to put in loss leaders. And the problem is, it's not just all the money that's lost in this circular reorganisation that's been going on in NHS England literally for the last 25 plus years, with people being made redundant and giving a big package, and then actually someone quite similar is re-employed, or they're re-employed somewhere else with a different title, health authorities to PCTs to CCGs. It is a huge waste of money that is being sucked away from patient care, and that's where you want the money to actually go.
I'm extremely grateful. The member earlier mentioned the Barking, Havering and Redbridge Trust at Romford. Part of that trust, it's the Queen's Hospital, but also King George Hospital in my constituency. We have another example. There is an independent treatment centre on the site at King George Hospital, where it was proposed several years ago to bring it back in-house. But the company involved went to court, and the NHS had to then concede it remaining as an independent treatment centre. These things are very damaging to the finances and integrity of our NHS.
Well, I'm afraid obviously it was the Labour Party who set up independent treatment centres, and one of the issues as a surgeon, as people know, was that they were sucking away the routine elective work which contributes to training future surgeons, and leaving the NHS to deal with the complex, chronic, expensive cases. And what we saw after the Health and Social Care Act was the NHS usually managed to find enough money down the back of the sofa that at the end of each year they would have about 500 million left. After the change, 100 million in debt, 800 million in debt, 2.5 billion in debt. And that's because money is sucked out in all of these different ways. And that is leaving a lack of funding, and therefore we're seeing rationing. And what the rationing is doing is actually pushing people to have to pay for more of their own care. And we're hearing that with co-payments, paying for a second cataract, paying for a second hearing aid. But through my choice, which the Health and Social Care Act also brought in, raising the cap from 2% to 49% of private income that an NHS hospital could earn through private patients. The highest at the moment is over 27%. And this idea that that doesn't impact on NHS patients is nonsense, because surgeons have a limited capacity on who they can operate during the day. And so if someone is able to jump the queue within the NHS, within the NHS, they are taking someone else's place. And what we see, and we saw that in the Warrington and Halton, who were actually pinning price lists up in clinics, was people being suggested that they might want to pay 7,000 or 8,000 for a hip or knee replacement. There were a lot of cosmetic and minor operations. But I would just gently suggest as a surgeon, surgery is not a sport. Either the patient needs an operation clinically, in which case it should be provided by the NHS, or they do not need it clinically, in which case they should not be able to buy it from the NHS. And so this principle of my choice, where hugely high thresholds are being set, some CCGs you have to have had 2 falls before you can have a cataract. You have to be in pain even in bed to get your hip done. which is driving families to club together to do that, is not right. Either someone needs it, the NHS is meant to provide that, free at the point of need. And if someone does not need it, every single operation is a risk and should never be done to attract in income for an NHS trust. Now, I will,
I thank my honourable friend for giving way, and I value your comments about how money has been sucked out of the NHS, but we have an issue in Scotland, particularly a large showpiece hospital in Edinburgh that should have been opened in 2012, 7 years ago, and that's sucking money from the NHS, millions of pounds annually over the last 6 or 7 years. You may wish to comment on that.
Well, it's not been sucking money for the last 6 or 7 years because it only was declared open in February. I totally agree that it is a huge setback, that in the end, due to a failure within the Health Board's tendering process for the build, they did not recognise the need for the level of ventilation within an intensive care unit. I would certainly gently suggest to the member, I do not think he would have wanted our Cabinet Secretary to simply go ahead, putting babies and children in an intensive care unit where the ventilation was not considered safe. The thing is that in Scotland, our funding so far for the NHS has doubled in the last 10 years and will actually increase further next year. But it's not just about funding, it's about structure. What's happening in NHS England is this fragmentation. It's not just NHS hospitals competing with private companies, they're competing with each other, and therefore that undermines collaboration. You need to have collaboration with the patient at the centre, and anything that fragments or undermines that collaboration is weakening the quality and the safety of care. Okay, for the last time.
The Honourable Lady is speaking very powerfully on many issues, as usual, but I'd be interested in her point of view on other health providers, because as she knows, and she's having worked around the world, many health providers do things differently, and particularly when one looks around Europe, for example. Many of those hospitals are not owned by the state. Many of those hospitals compete. Many of those services are provided by different companies, sometimes private, sometimes charities, sometimes by community groups. Would she have a comment on how many of those work? Because the French and the Germans seem extremely happy with their healthcare.
Well, as people will also know in this chamber, my husband's German. And therefore I know that system relatively well, and I would point out that actually there the hospitals do not collaborate either. As it is about income for the hospital, surgeons and clinicians will not always refer a patient on, even though they know there is an expert down the road. So I would not particularly defend that. And having lost my sister-in-law 2 years ago, and the bills were still coming in for almost a year, I think that's actually quite a stressful and upsetting system. Not everything is covered. Patients do still, as in many insurance systems, have to actually cover a gap. And that gap can still be significant and still be quite painful for people. They certainly could not generate the epidemiological data or anything like the treatment and outcome data that is generatable in all 4 of the UK health services, because they don't actually have a nationwide system. Now, I think it is important. I was back on the Health Select Committee for a short time this spring, and we heard talk about the changes to the Health and Social Care Act. And I think it is critical that they go ahead, because there are perverse incentives within them. At the moment, the tariff is only paid to a trust if patients are admitted. That is a perverse incentive for actually managing people in the community or even prevention. It is important that Section 75 is done away with completely, so that there is not a pressure on commissioning groups to put things out to tender. Because this is a wasteful process. I remember reading 500 million wasted in Nottingham, where they were preparing for a tender, then the private company didn't go ahead, then they did go ahead. All of this is taking money away from patient care. And that's what the argument is about publicly provided. The quips about drugs, etc. I'm sorry, that's just childish from the Secretary of State. Was he suggesting that nurses and doctors go into the North Sea to drill for oil, or that that's the suggestion from these bench? No, it's not. It is not the suggestion from anyone on the opposition benches that drugs would not be purchased. It's just a childish response. But having private companies who are pulling NHS England apart undermines it, fragments it, and makes it not patient-centred. And that should be the goal of every single health service right across the UK.